Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. Would like to start with thanking the SSBMT Society on this invitation, and would like to thank personally Dr. Ahmed for his kind invitation. It's my pleasure to be with you today talking about our experience with CAR T-cell at King Faisal Specialist Hospital. So I will try to summarize the topic today in outlines, starting with a quick introduction. Then we'll touch base briefly about the CAR T therapy programs at King Faisal Specialist Hospital and Research Center in Riyadh, following by patient treatment journey. Then I will present our experience and will present our pediatric data today. Then we'll talk about some challenges and obstacles in facing of these very challenging patients. Despite the significant advancement in the treatment of B-cell ALL, still the relapse and refractory disease remains a challenge for ALL patients. Relapse refractory B-cell ALL face very limited treatment options and poor prognosis. And before we have the CAR T-cell, most of them, they will be palliative care. CAR T-cell therapy offers a novel therapeutic approach, and the first CAR T targeting CD19 product was approved in 2017. The efficacy of CAR T-cell therapy targeting CD19 in pediatric and young adult patients with refractory relapsed B-cell ALL was observed in clinical trials with high remission rates and durable responses. The CAR T-cell therapy has demonstrated efficacy, but on the other hand, it's present unique challenges. The side effects like the cytokine release syndrome, ICANS, prolonged hematological toxicities with the thrombocytopenia and neutropenia, and B-cell aplasia leading to hypogammaglobulinemia and increased risk of infection were reported, and it's a major part of taking care of this patient that you should be on top of these things. In Riyadh, so initially we have the initial feasibility assessment phase for the program began in the fourth quarter of 2017. With that, the CEO asked Dr. Ali Al-Ahmari to lead this program. Then the CAR T-cell project team developed various committees and subcommittees to assess and determine the requirement of developing and maintaining the program. Clinical working groups initiated to safeguard the development of the required clinical practice, governing and training documents. Required documents were developed, staff training was initiated. The first patient was infused on 20th of December 2020. Nowadays, alhamdulillah, we are approaching 150 CAR T-cell therapy at King Faisal Specialist Hospital in pediatric and adult. All program developments, both operationally and clinically, as well as outcomes, are reported by the program chair to the MCA. Here is the program structures. We'll have the CAR T clinical coordination meeting, which will include the adult and pediatric CAR T-cell teams and the quality coordinator. You will have the CAR T laboratory coordination meetings, which involve the blood bank and stem cell processing lab and pheresis unit and the quality coordinator as well, and the CAR-T administrative planning meetings. They will report to the CAR-T program oversight committee, and they will report to the chief medical officer. CAR-T program is not easy. You should build your multidisciplinary team. You have the core CAR-T teams with the medical and nursing and coordinators. You need excellent collaboration with the pharmacy, with the apheresis stem cell lab and the manufacturing facility. And you need to have supporting teams, including the ICU, neurology, ID, emergency department, late effects, looking to the psychosocial support, and have good trials and outcomes research to see your results and express it to the national and international groups, and to learn from your experience. How the CAR-T cell work, as you know, so we'll collect the normal T cell where the virus is used to inject modified DNA into the normal T cell. After that, the genetically modified DNA produce a cancer specific CAR-T on the surface of the T cell, which will be a killer, and it will lock to the cancer cell, end by cancer cell death. Patient journey will start by leukapheresis of the patient. Then the product will ship to the manufacturing facilities where the T cell will be activated and expand. Then it will come back to the treating center where you will give your lymphodepleted chemotherapy, and you will infuse the T cell for the patient. After infusion, you will look for the CAR-T cell toxicities, cytokine release syndrome, ICANS, infections, febrile neutropenia, organ-specific toxicities are expected. Kymriah is the product that we are using for our pediatric ALL patients. As you know, Kymriah is approved for pediatric, young and adult patients up to 25 years of age with CD19 positive B-cell ALL that is refractory or in relapse post-transplant or in the second or late relapse. It indicated as well in the diffuse large B-cell lymphoma in adults with a relapse on refractory diffuse disease. What's the indication for CAR-T cell in pediatric? So what we are doing is screen our patients and the referring cases for the eligibility criteria to have the CAR-T cell. Refractory to first line is one of the indication when you are failing to put the patients in remission. To take the patients to transplant, then you may over CAR-T cell therapy. If you have refractory first relapse, the patient relapse and it's refractory, you could not put them in remission to proceed with the transplant. So it's another indications for patients to go to CAR-T cell. Second or greater relapse is an indications even if this patient did not had transplant before. If you have patients non-eligible for transplant, you have comorbidities that this patient will not tolerate the transplant, like the Down syndrome. Usually we didn't take them to the transplant, so CAR-T cell can be option for this patient. Any relapse after the transplant is an indication for CAR-T. So you'll start the screening of the patients, work up prior to before the apheresis. Then you will arrange the leukapheresis and the bridging chemotherapy in collaboration with the referring centers. Then once you have the product back, you will admit the patients in our unit for CAR-T cell infusion. So patients Normally they admitted for CAR-T infusion for 15 to 20 days. We discharge them after day 14, usually once neutrophils recovered and the patient is stable and afebrile. Patients will be discharged with CAR-T cell alert badge, and paper chart will have CAR-T alert sticker on the cover, so if the patients drop in the ER or other area, the sticker will be alerting the people dealing with the patient that this patient is post-CAR, as well as the ISIS documentation will have alert in the documents indicating that this patient is post-CAR. After discharging the patients, we ask them to stay in Riyadh for up to for like 2 months, like up to 8 weeks. They are coming in the clinic once to twice per week as indicated. Patients may be at risk for having CRS, ICANS, and infections after discharge, so the outpatients team should be conscious about these important factors. If unwell, if the patient unwell, they will attend to the treatment area during working hours, and they will go to the ER after hours. These are the stickers that usually the patients will carry, and it will be on the cover of the patient's chart. The pathway steps that it's really important to be clear between the referring centers and the CAR-T cell centers. You know, these patients are sick, and they are most of them, they need kind of inpatient and outpatient care, and it will be extra load on the tertiary centers who's doing the CAR-T to deal with all the treatment aspects. So having a clear pathway between the two centers is really a key factor. Once the, let's say, oncology centers having a patient that may benefit from CAR-T therapy, they should be discussed in the center's tumor board, agree about the CAR-T eligibility. Then they will contact the CAR-T cell centers. You will discuss the patients in the CAR-T cell centers in multidisciplinary team, will repeat the biopsy for confirmation of CD19 positivity. Once we have the confirmation, we'll start to work for the leukapheresis readiness as soon as we can. Then you will coordinate the bridging chemotherapy and the washout period between the two centers. The bridging chemotherapy is like a balance between controlling the disease and reducing the toxicities. We didn't ask the patients to be in deep remission before CAR-T cell. You can take the patients to the CAR-T cell even if they have some disease burden, but on the other hand, taking the patients with heavy disease burden is a challenge where you expect the risk of relapse will be higher and the risk of the toxicities will be higher. So balancing these two factors is really important when you are dealing with the bridging chemotherapy. Once we have the patients is ready for CAR-T cell infusion, will be admitted and will be infused, and you need patient follow-up and the treatment outcomes and adverse events in well-designed outpatient setting. So what about the pediatric data from King Faisal Specialist Hospital and Research Center? Here is our inclusion for the data that I will present. So I'm presenting here the pediatric patients below 14 years of age have CAR-T cell for relapse or refractory ALL at our department between December 2020 and July 2024. So time frame, as we mentioned, so from December 2022, where we have the first case, till July 2024, total patients, we have 28 patients underwent 29 episodes. We have 1 patient that we did 2 CAR-T because this patient relapsed with CD19 positive disease, so we over second transplant for him. 60% of the patients are male and 40 were females. The median age is 8.1 years, ranging from 2.6 to 13.2 years. Pre-CAR T cell transplant status, we have almost half of the patients never transplanted, and we have the other half had single transplant before they come for CAR T. What's the type of the relapse? Isolated bone marrow in the majority of the patients, up to 65%. We have 19 patients with isolated bone marrow. We have 6 cases with isolated CNS, and we have 4 cases with combined bone marrow and CNS relapse. Looking to the pre-CAR T cell treatment received, 40% of them, they got chemotherapy, they relapsed and referred to the CAR T without a prior transplant. We have 6 patients chemotherapy and transplant before the CAR T, and we have 6 patients with chemotherapy, immunotherapy, including either blinatumomab or inotuzumab before the transplant, and we have 5 cases with chemotherapy and immunotherapy. CAR T cell dosage, the median is 3.2 million per kg, ranging from 1.5 to 1.2 to 5 million. The median dose in ml is ranging from 10 to 34, with a median of 20 ml. The first admissions median was 24 days, ranging from 15 to 117. 117 this is like special case that is relapsed shortly and kept in patients for a long time. So most of the patients, they will ranging from 15 and 20. Our incidence for CRS, we observe it in 18 out of 29, so that's 62.1%. Grade 1 in 7%, grade 2 in 31%, and grade 3, 24%. We didn't have any grade for CRS in our cohort. ICANS, all ICANS observed in 3 out of 29, that's 10%. 2 cases grade 4 and 1 grade 1. We have 2 cases with status epilepticus that requiring ICU admission, so it's classified as grade 4, and we have 1 grade 1 ICANS. ICU admissions, we admit 13 out of 29 in the ICU. The median days in the ICU was 5. Inotropes was given in 8 of 29 with grade 3 CRS. Hematological recovery, if you look to the ANC recovery, the median is 14, ranging from 2 to 71. We have most of them, they recovered within day 28, and we have 1 patient who never dropped, and we have 5 patients never recovered within 28 days, so they recovered after. Platelets, the median is 29.5, ranging from 11 to 57 days. Comparing our incidence of CRS with the benchmark studies, they are like we have 62 in Ileana. The incidence was 77%, and in the CIBMTR registry with 25 centers from from the North America was 59. This is the ICANS incidence in our centers comparing with the others. Probably we having less cytokine ICANS complications. Overall survival, these are the curve with our overall survival. We have it 70.5%. The median follow-up is 13.5 months, ranging from almost 5 to 22 months. then the overall survival depending on the kind of relapse. So if you observe here, we have, as we mentioned, we have 4 cases with combined bone marrow and CNS. All of them, they are still alive. For isolated CNS, we have 1 mortality case post-transplant related to the toxicities. When we have the isolated bone marrow, so they are overall survival was 64%. So they are the lower in the group. Here is the event-free survival. If you noticed here, so overall is 58, but we have relapse. Unfortunately, is continuous dropping. So the line is declined. It's never a plateau. That's raising the concern that CAR T cell seems to be not standalone treatment as we believe, since we are observing even late relapse. So we have the first 2 cases that it's almost 3 years post CAR T, they relapsed recently. So this is raising the concern of continuous declining of the event-free survival curve in our cohort. This is the event survival based on the kind of the relapse. If you see here, the bone marrow relapse is doing worse, and they have a higher percentage of relapse and death after the CAR T. We lost 1 patient. We have 1 relapse in bone marrow and combined bone marrow and CNS, and we have 1 mortality in CNS relapse, isolated relapse with toxicities related to the transplant. So here is looking to our overall and event-free survival comparing with the benchmark studies. It's comparable to the international groups. If you look here, this is the our outcomes with CIBMTR registry. Even with the CIBMTR data, they are declining in the event-free survival curve and the overall survival. So that's highlighting the risk of relapse even after good times post-transplant. With Ileana study, again, there is a continuous dropping in the event-free survival. If you look to the outcomes at 6 months, it was 71, then it dropped gradually to 44 at 36 months, and maybe will be less after longer follow-up duration. So that's raising the questions. Is the CAR T cell can be a standalone, or you need to consolidate the CAR T with transplant? It's really difficult questions. Probably transplanting all of the CAR T cell, maybe it's too much and like over-treating, while on the other hand, if you give the CAR T and just CAR T therapy without transplant, maybe you are under treating some groups of patients. Trying to answer this, we look to our data and comparing the outcomes of patients underwent transplant post-CAR T, comparing with patients who got only CAR T, and there is a trend showing that there is better outcome when you transplant the patients post-transplant, post-CAR T. Again, for event-free survival, again, the trend is small sample size, so the p-value is not significant, but there is trending better outcome when you take these patients to the transplant. So the questions, which group of patients you may consider them for transplant post-CAR T? We have some criteria that we all and most of the international groups agree on. and there is a gray area that it's really need very extensive evaluation of the patients and discussion to decide which of them should go for transplant. If you have infantile and non-infantile leukemia with MLLG rearrangement, definitely you will consider the transplant post because there is a risk of lineage switching in this group. If you have positive MRD post CAR T-cell infusions, this is an indication for transplant. What's the timing that you take it in consideration and take this patient as positive MRD? Probably between 60 and 90 days. Definitely day 30 is still early. You may have positive MRD. You will give more time for the CAR T to work. By day 90, if still there is positive MRD, the risk of relapse will be high, and considering this patient for transplant will hopefully give a better outcome. Early recovery of normal B cells on the routine lymphocyte markers monitoring. Again, the timing is there is conflict about which time you will consider it early. Definitely less than 6 months of B cell recovery. That's indicate weakness of the CAR T, and the CAR T is getting function is getting less and less, and the risk of relapse will be high. So we all in our centers agree that early recovery of the B cell less than 6 months is an indication for transplant. After 12 months, if the patient clinically is fine with negative MRD, there is no indication for transplant. Between 6 months and 12 months is the gray area that you may have conflict and different opinion. If you have remaining bags at the manufacturing lab, you may consider reinfuse of the CAR T when you have early B cell recovery. But if you don't have, so definitely this patient should go for transplant. What we are discussing now, and probably it will be our next direction, is transplanting the patients post-transplant if they didn't have a previous transplant. So if you have, even if the patient is doing well, achieve remission, still we are observing relapse. So probably consolidate the transplant, the CAR T cell with transplant in well preserved patients is a way to go. If you have patients who had transplant before the CAR T, it will be really toxic to take them to the transplant unless they have positive MRD or strong indications. So that's the, let's say, the bright aspect of the CAR T cell program. But on the other hand, we have a lot of challenges. Remember, these patients are very sick, and a few years ago they are palliative, so they will be referred to you to take care of them. Some of them, they will come with an impression that it's the CAR T is very easy, and it's like a piece of cake, and it's easy to put the patients for CAR T, but this is not the reality. You may have difficulties in collecting the T cell due to disease progression. If you have like very active disease with peripheral blast, let's say more than 80%, and there is no normal neutrophil, so you could not collect the normal T cell. So these are issues. You may have a trial of collection, then you will send it for manufacturing, but it may get failed before because the low counts. You may collect and send, but it's failed due to contaminated product, and we have it in 2 cases that we sent this and the product was contaminated, and we recollect again. You may collect, manufacture, and the patient has uncontrollable disease and get sick and not ready for having the CAR T infusion. We have patients who we were unable to infuse because the active GVHD, and you know the active GVHD is contraindications for CAR T. heterogeneity of the CD19 is a really important point to discuss, and be sure with and review it for every single case with our colleague in the hematopathology. You should have a homogeneity of CD19 expression. Having patients with partial expression of CD19, you may have the other clone get relapse after the CAR-T, and we have one case like with partial expression and relapse shortly after the CAR-T with CD19 negativity. Going back to the previous reports, they look and say, okay, this is partial expression, not full expression of CD19. So taking this point is really important. You may delay the CAR-T in patients if you have unresolved serious adverse reactions, if you have active and controlled infections, active GVHD, and significant clinical worsening of leukemia burden that's lead to a delay in the CAR-T infusion. So the conclusion, CAR-T cell therapy over the novel, a therapeutic approach, and hopefully in the near future we'll have more CAR-T product targeting more cells. It gives high rates of remission and durable responses. It seems that it's not standalone treatment, at least in a group of patients. A transplant post-CAR-T seems to increase the overall survival and event-free survival that may consider and balance it with the toxicity, the expected toxicity from the transplant. Thank you for your listening, and would like to thank all the people who's working for this program, starting with the higher administration of the hospitals and the core CAR-T programs, and all the multidisciplinary teams, and all of our patients and their family. And thank you for your listening.